Good morning. Oops. All right. I think we probably have enough people to get going. So good morning, everybody. All right. All right. So this is a LAO projection of an ablation. And the question is, name the catheters and where is the ablation catheter? So why don't we ask Dr. Capon what she thinks about let the catheters lettered or labeled A and B. And then the last question is, where do you think the ablation catheter is? Uh,
Give us 1 sec. We're getting audio figured out. Sorry.
no worries.
I muted it.
Okay, I think we're good.
Yeah. I can't hear Ivana. Can you guys hear Ivana?
It's
Maybe I'll
can,
just stand
can you
next to
can you hear her? Can you hear me?
I can hear you.
Yeah, Ivana is on my phone.
Can you hear me?
Yes, very well.
Sorry, my AirPods are being dodgy. All right. So looking at the ablation catheters, we have one in a position that's more what appears to be anterior, and one that appears to be posterior. So starting with A, I'm going to start with B actually. So it looks like B is.
Just a tiny bit trouble hearing you, Ivana.
It looks like B
Uh-huh.
is situated posteriorly, and there are a bunch of different nodes there. So I'm going to say this is the coronary sinus catheter.
Okay, I would agree with that statement, right? So typically a coronary sinus catheter has either 8 or 10 electrodes for 4 or 5 bipoles, and in this case it's a decapolar catheter with 10 electrodes or 5 pairs. Okay.
And it's also coming what appears to be from superior axis. So it's probably someone who's gotten access through the neck. Well,
Agree.
and then looking at A, so traveling inferiorly, superiorly. To me, I believe this is
Having a bit of trouble hearing you, Ivana.
Atrial cap, high right atrium catheter.
Well, I guess it could have been, but it's not the high RA catheter. Actually, this catheter that's going off the screen is actually the high RA catheter.
Okay, so maybe the
Yeah, this is the HIS catheter, which in this particular image, the operator is using a quadrupolar catheter. So you could record a HIS from the distal to the second electrode, from the second to the third, and then from the third to the fourth. So you could have basically 3 projected HIS electrograms on the intracardiac recording. And where is the ablation catheter, do you think?
it looks like I'm going to say it's probably near the cuspid. I think it's in the right atrium near the pickup valve tissue.
Having a little trouble hearing you, Ivana. I'm sorry.
I think it's in the right atrium. The kind of near the tricuspid valve tissue, just based off, or near the triangle of Pope, just based off where the coronary sinus catheter is. The only other thing I would consider is that I don't think it's crossed over into the LA because I don't think it's super distal. But that would be another differential.
So the coronary sinus vein sits where in the heart, Ivana?
It runs inferiorly in the AV group.
Boy, it is hard to hear you.
Inferiorly in the AV group.
Inferiorly, well, it is posterior, but around which valve? The mitral or the tricuspid valve?
It passes through the uh,
Doesn't pass through either. It's around one of them.
around, sorry. So it passes around the tricuspid.
No, it's around the mitral. Remember that the coronary sinus catheter is we sometimes people, I think it was Dr. Walsh in Boston who once joked that the coronary sinus is God's peephole into the left atrium, right? So the whole benefit of a coronary sinus catheter is that it sits around the mitral annulus, allowing us to see depolarization on the left side of the heart without actually going into the left side of the heart. Okay. And so whenever electrical signals are recorded along the coronary sinus catheter, the likelihood is high that it's recording left atrial signal. So the nice thing about the coronary sinus is, of course, because it's sitting at the level of the annulus of the mitral valve in most patients, it is recording both atrial and ventricular impulses at the same time, both LA and LV signals at the same time. And when you're looking at an LAO projection, and you see the coronary sinus catheter, so the mouth of the coronary sinus is going to be somewhere around here. And so if the catheter is coming up like this and going all the way posteriorly like it is, so that the tip is somewhat near to the coronary sinus catheter, then by definition, it's in the left atrium. So this is a patient in whom a transeptal puncture was performed. And if you see the His catheter here and the mouth of the coronary sinus here, the triangle of Koch is going to be down around this area. Whoops, sorry. It's going to be down around this area here. And so basically this is where the atrial septum is. And so the sheath is essentially going through the atrial septum into the left atrium, and then it's being retroflected down onto the area near the mitral valve. Does that make sense?
Yeah, thank you.
Okay, so this was actually a case of a patient who had a left atrial tachycardia, a ectopic atrial tachycardia with a tachycardia-induced cardiomyopathy, and came to the cardiac cath lab at that time with an ejection fraction in the low 40s, and just 1 week later, after successful ablation, the ejection fraction was 55%, showing that what we know, which is that tachycardia-induced cardiomyopathy is one of the very few causes of cardiomyopathy that is reversible by getting rid of the arrhythmia. Okay. All right. This is a tracing I got from Twitter from Dr. Musikbrot. I'm sure I just completely butchered that gentleman's name. On the left-hand side is the tachycardia of this patient. And on the right-hand side is the sinus rhythm of this patient. So this is a 3-day-old. So my question to the audience is, what is the diagnosis, and how, if at all, would you treat this? So why don't we ask Katoki what she thinks?
Good morning, Dr. Katz. Looking at the sinus, the EKG showing the sinus rhythm, the regular sinus rhythm of this patient, looking at the looking at the D, I think this is I guess D2. I guess this is the lead 2. So the first 1, 2, 3, 4, 5 beats of sinus, and then for the next 3 beats, the QRS morphology has changed, and I don't think I can make out a P wave in these. And there's a pause, and then we have a host of sinus beats again, and then we have non-sinus beats. So the QRS morphology is different from the sinus beat morphology. So I would think this originates and it's wider. So I would think this originates in the ventricle. So so I would say there are like 3 beats of beats which are originated in the ventricle, and then we have sinus beats again.
Right. So, and what do you make? I agree with everything you've said there. So what do you think this tracing is on the left-hand panel here?
Uh, because it's the same patient,
It is the same patient.
and I'm looking at lead two again, and the now all the QRS complexes, or all the beats do not have. I don't think there's a key wave in front of those leads,
I agree.
and they also like resemble the beats that were there, which were intermittently following the sinus rhythm. So I would think this is a ventricular tachycardia.
Yeah, I mean, I don't know if we would call it, I agree with you, it is ventricular. I don't know if we would formally call it VT. You might call it an accelerated ventricular rhythm, but it is certainly not sinus. And I think the teaching point in this tracing is, of course, we have the 12 lead in sinus, but sometimes we don't. Sometimes, when you're called to see the patient, they're doing what's on the left-hand panel, not on the right-hand panel. And you don't have uh, the advantage of having a sinus ECG and a non-sinus ECG. I think when you compare these two, just as you eloquently stated, Katoki, the QRS morphology is very, very different, right? We have this very, very narrow QRS. There's a rightward axis on the sinus beats, as we would expect in a newborn or a 3-day-old. Whereas in tachycardia, the QRS is very different than the QRS in sinus. We don't have the rightward axis anymore, and the QRS is also a little wide. If you had not had the sinus ECG, if you just saw this, you might be inclined to think that this could be a sinus rhythm, or maybe junctional rhythm, because the QRS has a normal QRS axis, right? It's upright in in AVF. But the point I'm trying to make here is, first of all, having both of them side by side is very helpful in determining what the actual arrhythmia is. But the other important point is, in babies, VT can be very minimally wider than average or normal. This is a very nice example of this, where the QRS is just a little bit wider. So this is an example of an accelerated ventricular rhythm. So if you were called to see this patient, Katoki, you've now made this diagnosis correctly, which is that the child has an accelerated ventricular rhythm. What sort of testing or evaluation do you want to do for this child? I should also mention the child is totally hemodynamically stable in both rhythms.
If Okay, no. If this is a baby presenting with accelerated ventricular rhythm, and my understanding is it's not something that is very concerning. So, and if the baby is hemodynamically stable and doing well, I would just ensure that that's fine, and I would observe the baby, and if they continue to have it, I don't know, I would like err on the side of caution and maybe get an echo to look at the function, but I would not be too alarmed if they have an accelerated ventricular rhythm, because I would think that's not as ominous or as bad as a VTAC.
Right. So, okay. Any other? So I agree with you. In general, we'd not be as concerned, but how would you make yourself feel better about it? So, some people have VT and it's not
I
with.
would do it. I'm sorry. Sorry, Dr. Pass, I interrupted you.
No, go ahead. Go ahead.
I would do an echo to look at the function to see if it's fine.
Yeah, you go to do the function. You might also, we've talked about how some groups think that there are these little tumors in the ventricle that could be causing VT.
Right.
I'm not sure I've ever seen one, but maybe, as someone once said to me, you have to know what you're looking for, I guess. But certainly the function and the dimensions would be important to confirm that you're not, having dysfunction on the basis of this. Although we would not expect that, since the rate of this tachycardia is only slightly above 150, in a newborn, I don't think we would expect that would cause dysfunction, given the normal heart rates of newborns. But anything else, like if this was like in the well baby nursery, would you send the child home that day? Like this is a typical thing, right? It's Saturday and it's 1:30 p.m. and the parents want to go home. It's day of life 3, and this was diagnosed. Do you say, oh, it's okay, continue packing up everything and take the child home, or would you do something else?
I would also like look at the serum electrolytes to see if they're fine and there's nothing going on there.
Okay, that's a typical answer, and as is
Um,
always the case, they're normal. But I'm not disagreeing with that, but they virtually never are abnormal. But
I
would
would
you
like to,
would
yeah,
you want
I
to
would like
watch this? Do you want to
I
just
would like to watch it for a bit and
right? You'd want to
see what
know,
the, yeah,
see what, see what.
see how the natural progression of this is, like whether it terminates by itself and whether there are short bursts, whether it keeps on coming back. I would like to see that and for how long it's lasting.
Right. I mean, I think the important thing is, what percentage of the day is the child spending in this rhythm? Uh, how fast is it? In this particular example, it's not that fast, but do we know that maybe this is the fastest it ever gets, in which case we would be less concerned? Or maybe there are times where it's actually much faster than this, and this is in fact the slowest that it ever is. So we would definitely want to at least monitor this for 1 to 3 days on telemetry in order to get a better flavor of how frequent this arrhythmia is poking its head out. Now, the family is now very angry with you because you've just explained that, they just passed their car seat test and you're telling them, no, 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 you can't go home. This child, not only can you not go home, this child has to go to the NICU for observation. So now they're very nervous and they want to know like what's going to happen to their child. Like, what is this going to be a lifelong problem for my little baby Ethel? Is that the what do I have to worry about now? So
Um,
I tell them about the natural history of this arrhythmia.
I would tell them that it's not, I would tell them that the reason I'm asking them to stay for a few days is because I want to see how the thing progresses. But
Yes,
otherwise, I would reassure them because I would tell them it's like it's usually self-terminating and it's usually does is not it just goes away with time and as I said, I would do an echo to
right,
see the function and I'll just reassure them more.
right.
But
That's
I'll ask them to stay.
yes, okay. So right. So the natural history, as you said, is that it typically resolves over the first 6 to 12 months of life, even earlier sometimes. And so the natural history and the expectation of the prognosis would be very positive. Um, but you would want to see how much the child's in it. And different people have different feelings about how aggressively they would treat this type of arrhythmia. Um, and I think a lot of it would depend on how fast it is, what percentage of the day the child spends in it. And typically, you could use almost any arrhythmia medicine for this if you thought it had to be treated. But I think most people would probably start with something very simple, like a beta blocker, like propranolol, for example. Okay, good job. Thank you.
Thank you.
All right. So this is a tracing that I saw on a Zeo patch and was obtained at 5:19 a.m. And what do you think is going on with this rhythm? And if you had to describe this in your report of the Zeo, how would you describe this? Let's ask Dr. Bezdakova.
Good morning, Dr. Pass. So looking at this rhythm, so there's P waves before every QRS, so I'd say we're in sinus rhythm.
Mhm.
And then looking at the R to R interval, it does vary. But since we're in sinus, I would say sinus bradycardia with sinus arrhythmia.
Uh-huh, I agree with all those statements.
And then
What do you make of
um,
this, Pete, here? This is, by the way, not a complex question. I'm not trying to get you there. I just want to really point something out about nomenclature. So what do you make of this one beat here compared to all
um,
the others? Actually,
the
and also looks a little different too. This
the
this beat.
yeah the P wave looks slightly different than the preceding P
Mhm.
wave.
Or the following P wave. Right?
Yeah, or the following one.
So is there a term we use so if we saw this at a fast rate, like the first patient today who had ectopic atrial tachycardia, we would call it ectopic atrial tachycardia. But what do you
Mhm.
call it when somebody just has a random P wave here or there that is not a sinus P wave, right? It's clearly different than the sinus P waves. Is there a term we use for that?
A topic P wave or
Yeah, well, you could call it an ectopic atrial P wave, slow one.
mhm.
But sometimes an old-fashioned term, which is still used a lot, when you see somebody asleep and their sinus node kind of goes to sleep with them and they have this kind of escape P wave, different P wave, sometimes people will refer to this as a wandering atrial pacemaker.
Mm.
Which is a normal finding, is typically seen on a Holter or ambulatory monitor when the patient is asleep. And it just basically reflects the sinus node alternating with a non-sinus focus that is very, very slow. So it is an ectopic atrial beat, but it's very dissimilar, for example, to the EATs that we will not infrequently, be worried about. In this case, this would be basically a normal finding in healthy people, sometimes that you see when they're asleep. So, one way to describe this would be to say, the periods of wandering atrial pacemaker while asleep. And that is basically a normal finding. You don't have to describe this. I often don't when I see this, but that's what we would call this. Alrighty, this is an example of an EP study in which the doctor is rapid atrially pacing the patient. And so we'll just go through the legend here. So the first four channels are electrocardiographic ECG. Then there's a distal and proximal map, a high RA, His proximal to distal, and then CS proximal to distal. And actually, the His is all over the place, distal, proximal, and mid. I don't know why the mid is below it. But anyways, here's proximal CS. This patient only has 4 pairs of their coronary sinus. So 7, 8 is the proximal, 5, 6, 3, 4, and then CS distal way out on the left lateral. Here's right ventricular apex, and then here's the stim channel. And this comes from Dr. Mustafi Neuuchi, who's got an Instagram account that I follow with interesting ECGs. Anyways, and Dr. Neuuchi seems to have measured the R to R or the stim to stim interval at 234 milliseconds or 256 beats per minute. So what is this EP Dr. Neuuchi trying to demonstrate for us? I'm going to ask Dr. Molly Marshall.
Good morning. So looks like we're rapid atrial pacing at around 250 based on how they calibrated out there.
Mhm.
In terms of what are we trying to prove?
Well, what do you think about the QRS if we're rapid atrial pacing?
The QRS looks wide.
Okay. And when you look in the coronary sinus pairs, is there any suggestion of what the etiology of the wide QRS might be?
So it looks to me like an accessory pathway, I think, because it looks earliest in the let's see. Looks earliest in the 7-8.
Well, actually, um, what do you think about, so you're saying this, so in the 7/8, this would be the A and this would be the V, okay?
Oh, sorry, I like mixed up. No, so it's not. It's earliest in the distal,
Right,
which is at the bottom there.
right. So this A and
Yeah,
V are almost on top of one
yeah,
another. And as
yeah.
we move closer to the
And then
mouth
you
of the
see it,
coronary
yeah.
sinus, it gets a little wider apart. So where do you think the accessory pathway is located, Molly?
So if it's distal on the CS, then I would think it's a left-sided pathway.
Yeah, like a left lateral pathway.
Yeah.
Remember from this, right? If it's distal on the CS, you're talking
Mm-hmm.
about way out here somewhere.
Yeah.
So, okay. And why is Dr. Niucci showing us that the pre-excited RR interval with atrial pacing is 234 milliseconds?
Oh, because we're trying to show that we're trying to demonstrate the risk of the pathway.
Uh-huh. And so,
Um,
what is your determination of risk based on or assessment of risk based on what he's demonstrating to us?
so I think here it's like with it being 234, that puts it under the kind of line drawn as like 250 or so being high risk.
Right, right. So this is a very high risk pathway, right? It can conduct at rates of 256 beats per minute or a cycle length 234.
Mm-hmm.
So, uh, right. So the lower the cycle length, of course, the faster the rate. So, and I might add, we don't actually see loss of pre-excitation. It might be even that at a faster rate, it's still
Right, it's still there. Yeah.
so the truth is you don't have to go lower than this. You don't even have to go this low because once you get to 250 milliseconds, you are actually in the high risk category. So, okay, so you've done this testing. If this were an asymptomatic wolf, what would you do, Molly, based on this information?
I mean, I think you've demonstrated here that it's a high risk. So try to see if you can ablate it.
Yeah, that's right.
And so you would have to do with it being left lateral, then you'd have to do a transeptal approach as well.
Yeah, yeah. I mean, the most common approach would be to do a transeptal and ablate this. And I agree. I think almost everybody would ablate somebody who could conduct one-to-one to cycle length 234. Um, just as an FYI, or in the interests of completeness, there are electrophysiologists who will do this type of an ablation retrograde. They put a catheter in the aorta and they go over the aortic arch through the aortic valve and then retroflex the catheter backwards across the mitral annulus, and they ablate pathways that way. That seems perhaps to you, because both Dr. Love and I do ours transeptal, and may seem like a very complicated maneuver to do. It seems that way to me, but actually, the literature would suggest that the efficacy of doing it that way is just the same as if you do it prograde. And in an era before atrial fibrillation ablations, which of course require the operator to go transeptal, most adult electrophysiologists did not like going transeptal. They thought it was very dangerous and scary. And so up until the era of AFib ablations, I think it would be fair to say that most adult electrophysiologists would ablate left-sided pathways retrograde on the theory that going transeptal was very, very dangerous and carried a lot of risk. Once they got facile with transeptals, because of the requirement of that in order to do AFib ablations, I think the majority of them have now moved to doing it transeptally, as you see Barry and I do these because, well, I personally think it's easier that way. But again, those who do it retrograde would tell you it's very straightforward for them to do retrograde. Turns out that there are probably certain areas where it's easier one way or the other. For example, left lateral pathways in general are a little bit easier to ablate transeptally, whereas pathways that are very close to the atrial septum, so like left posterior septal pathways, are probably a little easier retrograde, because as you know, and you can see it from this image, if the pathway is located, for example, this would be, so left lateral out here, and posterior over here. So if you're going across the atrial septum in this direction, you could imagine that you have to then retroflect the catheter back, and sometimes it can be challenging to get the catheter to go all the way posterior this way. Whereas to go out here, it's actually fairly easy going transeptally. And in similar vein, when you're going retrograde, it's actually easy to retroflect the catheter back up into the medial portion or the posterior portion of the mitral annulus. A little bit harder to do it, to move the catheter in this region here. And so each has its own approach, and you know, there's no right answer, but I think in 2024, probably fair to say that the majority of electrophysiologists do their left-sided pathways transeptally. Okay, I think with that, I'm going to stop for today. Any questions about that one? All right. Thank you all very much. Hope you all have a great day. See you in Sinai a little bit.
Thank you.